one way or another. So we're going to do exam 3 review. That will be given next week. It is the same sort of questions as you're used to. And the math is the same, mLs per hour. You might see an insulin drip dose, one of your DHQ questions, but just like it's been in, it's no changes in it. So let's get going with this and get it. All right, put you on mute. All right, it's a lot of chapters. So it's like really hard. What do I study, right? Chapter 6, 7, and 8, and then we're going to give that exam on 9. All right, first of all, we're going to talk about respiratory. Now, respiratory, it's about breathing in and out, right? Now, the red blood cells in our body goes up to the lungs, collects the oxygen, and brings it around to our body, right? And the cells that do that are called erythrocytes. So erythrocytes are what carries oxygen to the cells. Now, one thing that's always been a confusion with students, what should be a normal oxygen saturation for these children? You know, adults, they say 92, but when you're talking about children, you're talking about 90. So 90 is where it should be. Trying to check one thing here. All right, making sure that I was recording. So 90% should be your normal saturations. Now, what do you see if a child's in respiratory distress? Well, they can't catch air, right? So they're breathing fast. When you listen to their lungs, they're going to have sounds, whether it's rales, rhonchi, wheezing. You're going to see intercostal or supraclavicular wheezing retraction. They're right between those clavicles on infants. This only in children, the small ones, you'll see that pulling backwards towards the back. And then you know you're in real trouble. You will absolutely see some cyanosis because your O2 saturations are going to be low. And in older children, you're going to see that irritability or confusion. You'll see a little restlessness in an infant, but mental irritability and confusion in the older children. And of course, you're going to hear some sort of stridor, some inability to get air in and out. Now, what's another name for the common cold? It's called coryza. It just allergies, no fever, sneezy, and itchy. Okay, so there's allergies, which is all of that stuff that's related to contact to something, and coryza is a common cold. Okay. Surfactant is something that at actually they say it starts about 24 weeks, and what it is by 34 weeks at birth, it's the substance that holds the alveoli in the lungs open. It is that has the ability of exchanging of the oxygen and that carbon dioxide. Well, sometimes this surfactant doesn't work. It collapses. So a collapsing of those alveoli is called atelectasis. That's when you can't hear breath sounds there, right? That could happen post-operatively to a patient that's not doing really good pulmonary care. Now, some of the common illnesses in pediatric children are RSV. Now, RSV from you and me, it's a common cold, but RSV is the single most important pathogen that causes a viral type pneumonia in infants. And infants struggle to suck, swallow, and breathe normally. So add that extra mucus fever, you can see that could have a problem. What we do with children, infants with a fever, we need to give them a little bit of extra fluid because fever does burn off fluid and we don't want them to get dehydrated. Asthma is one of those chronic respiratory illnesses in children. It is the most principal cause that school is missed while children go to the ER and for a lot of hospitalization. So asthma is a chronic condition. Many children grow out, but some don't, and they live into adulthood with it. Now, cystic fibrosis is a two-component disease. It is a component that, number one, it causes thick secretions in the airways, and it requires great pulmonary toilet. You want to get it thick, thinned, and get rid of it, okay? But the other component of cystic fibrosis is getting the body to digest food so it can be used for the body. And if you can't digest it, the food nutrition is lost. And children need nutrition, nutrition, nutrition. So what would you feed a child with cystic fibrosis? Well, cystic fibrosis, we need to give enzymes for. We know that they're going to have these really foul smelling frothy stools, which is part of the fat. So we don't want to give these children fat. So we're going to give them high protein and high sodium. Now, why high sodium? Well, what do we test cystic fibrosis? What's the name of the test? It's called a sweat test, and we're testing for sodium. So as you can see, there's going to be a loss of electrolytes, specifically sodium, through the sweat. So we need to replace that. Another thing that can occur is infertility, especially in the male. You need a lung transplant, bilateral. 1 year later, they can attempt to have children. Now, laryngeotracheal bronchitis is another name for croup. It's the larynx, the trachea, and the bronchus get swollen. And it's inspiratory stridor, it's swollen. You can't get air in. Now, they can get it out okay, but getting it in is really hard. You're going to hear that high-pitched sound like as they're breathing, okay? Now, if left untreated, it will turn into epiglottitis and is caused by the H influenza. And this is a life-threatening emergency. That epiglottis swells up, covers the trachea, and you can't get air into your lungs. So it is a life-threatening emergency. That child probably going to be intubated or get a tracheostomy pretty quickly. Now, there are some terms that you need to know. Tachy means fast, brady means slow. Dys is like abnormal, like dyspnea, difficulty breathing, right? Hypoplastic. Well, hypoplastic means abnormally small or underdeveloped. We hear that in the cardiac with a hypoplastic left heart. That's when the left ventricle is hypoplastic, small, and it doesn't function. Another thing that happens in cardiac is what we call a shunt. And it's where blood flows from the lower pressure, from the higher pressure to the lower pressure. For instance, if you had a hole between your two upper chambers, the atrium, it would flow from the left side over to the right side. Because just think about blood. It comes back and it just gets back, from circulating the whole body into the right atrium. So pressure is very low. The left side has it flowing in from the lungs fast. So it goes left side back to the right. And then what happens? Well, it goes back into the lungs again, and it just keeps the lungs flowing. It's just extra flow. Now, a murmur is something where you hear blood flow working a little bit differently, where it could be a valve or it could be a hole between something. Usually when I think of a murmur, I think of a sound in that heart instead of a right? That's what it really sounds like. Now, cyanotic is when you have not enough oxygen and you could become bluish. Acyanotic in cardiac is that heart has a defect, but it's not affecting how it's getting its oxygen. I mean, that ASD, that hole between those upper chambers, is a hole, it's a defect, but it's just recirculating blood into the lungs. It's still full of oxygen, so that's acyanotic. And stroke volume is the amount of blood pumped with one contraction. Now, as I just said, ASD, right? That's that hole. It goes from the left side to the right side. So it increases blood flow to the lungs. How do we treat it? Well, we could either go and surgically repair it, or there's actually a cardiac cath procedure. I'll call a Helix device. I was in the hospital that first developed it. And it's this little thing that they put up through the cath, and it has two like plates. So they push it through one side, it pops open, and this side pops open, and it covers the hole and prevents having surgery. So cuff can be done too. A VSD, well, this is your lower chambers, right? Again, left ventricle's pumping, so there's a lot of high pressure. So the shunt goes from the left to the right, okay? And again, more blood flow into the lungs. Treatment, again, it could be cardiac cath, sometimes surgery. And remember, some of these are so small, they just go away as the child grows. Now, a patent ductus arteriosus is something that's there for fetal circulation. And it's a little opening that really saves a lot of infants' lives when they have some cardiac defects. It connects the body, the aorta, to the lungs, the pulmonary artery, and it gives oxygen when we need it. It normally, right after birth, mommy stops producing a hormone called prostaglandins, and it closes within the first 2 to 3 weeks, usually a couple days, it's pretty well closed, but they say up to that. Well, sometimes these ducts don't close. I see it a lot and more in the premature infant. So they can give a medicine called indomethacin. And we know it's closing as we're giving that medicine when that murmur that PDA causes, and you could hear, disappears. And we could also look at it with the blood pressure. We can tell there. Usually that is done with the indomethacin, but again, surgery or cath. Now, a coarctation, I call a kink in the garden hose. You got that blood vessel coming off that left ventricle up to the aorta, right? Big old aorta going and supplying the whole body. Well, there's a kink in it. It restricts the blood flow going to the lower extremities. So you'll have decreased pulses in the lower extremities, okay? You'll have higher up above because there's more blood flow there because it can't go down, it's got to go back. So you'll higher in the upper extremities, lower in the lower extremities. And because it's backwards, blood can't go down, it goes somewhere. And what happens, it fills up the lungs, congestive heart failure. We treat that by surgery or balloon cath. Now, tetralogy of Fallot is one of the cyanotic heart defects. And this is the child who is going to have these tet spells, as we call it. And it's all of a sudden the pulmonary artery spasms, the blood can't go up into the lungs, and now you're not being oxygenated. So what do? As a nurse at that time, you need no order for it. You put that child knee chest quickly. And that somehow changes the pressure in the abdomen and the chest, and it pops open the valve, and now we got blood going back. This will be having surgery. They do need repaired. Some are done at birth, some are done later. It all depends on how the defect is. And you'll see these 4 things with all of them. Now, it's all on the right side. That is a right-sided defect. So you're going to see a pulmonary stenosis. That's the right side from the right ventricle. You're going to see that ventricular septal defect. That's a connection. That actually is a pop wall valve when you have a TET spell. The aorta sort of pushes over. That's what overriding means. And because sometimes when that valve shuts and we can't get blood up in there, that right ventricle stretches a little bit and it causes what we call right ventricular hypertrophy. It stretches, but in time it can strengthen and return normal. Again, surgery is required. As I said, hypoplastic left heart is a small left ventricle. And there are multiple different surgeries that need to be done. That PDA, we need open from birth. We do 3 surgeries. We do a shunt, then we do a Glenn, then we do a Norwood. It's all trying to connect all of the parts of the body to the heart to make it work because it doesn't have an engine. There's no left ventricle. It doesn't work. So it's a small left ventricle. Now, things you need to know about the heart. When we go and we look at things like coarctation, we might have to go ahead and look at that aorta, right? The name of that test, which is X-rays of the aorta by putting some opaque dye in there. We shoot it in there, take a picture, and we could see, is the aorta open completely or where's that kink? So an aortogram. An echocardiogram is after we get an infant or a child admitted with a cardiac anomaly, or supposedly, we're going to be doing an EKG and then we're going to do an echocardiogram. And that's going to tell us if the structure in the heart is normal. And from there, they'll go to cardiac cath if they find anything, and then maybe surgery. Now, sometimes, like with that coarctation of the aorta, blood goes back up into the lungs, fills it up, goes to congestive heart failure. What do you see? Well, you're going to see a sudden weight gain. That's why in the hospital, we are going to be doing daily weights on every kid that's in there. They do all of them. This child will be tachycardic at rest. That heart's going to be beating like crazy, even if they're just sitting there doing nothing with no strain. And you're going to see them really short of breath. Now, one condition that can affect the heart is strep throat. Now, strep throat, we should always tell our parents to take the entire dose of the medication because it can cause all different infections. It can cause your pneumonia, rheumatic fever, meningitis, glomerulonephritis, otitis media. And how do we treat all of these infections? I mean, rheumatic fever is heart damage if we let it go on too far. We're going to be giving them penicillin. And that's the biggest one to get rid of these complications when all of these are due to strep throat. So anemia. Anemia is what? Decreased red blood cells, or you're going to be seeing your hemoglobin hematocrit is going to be really low. Now, when you don't have enough red blood cells, you are anemic and you're going to be tired all the time, right? Now, there's different types of anemias and whether they're decreased production or loss, let's go into that. Now, iron deficient anemia, and it's caused by nutrition. And it's just because they're not eating enough iron. Now, what would we encourage? Well, I know no kid wants to eat liver. Actually, my mother used to make the best liver, but you know, I'm old and that's what we used to eat. But green leafy vegetables, things like broccoli. My grandson loved broccoli. Any green leafy vegetable can help. And that just nutrition can be enough treatment for iron deficient anemia. Now, what is that hereditary blood disorder? Blood doesn't clot? Well, that's called hemophilia. And remember, that's hereditary. It comes from mom and dad passing on the trait. What is a hereditary blood disorder where the body can't produce enough adult hemoglobin? You know, this is the disorder that comes actually from descendants of the Mediterranean Sea, and it's called thalassemia. And what happens is these cells just keep bursting and bursting and bursting. And it's called thalassemia. Or it's another name they call Cooley's anemia, but thalassemia is a broad name, is fine. What hereditary blood disorder where red blood cells change their shape to find a crescent? Well, again, that is sickle cell anemia. Now, in a crisis, we've got all of these cells bunched up like crazy, and they can't pass through vessels. Our priority for this is to rehydrate these children, get those vessels bigger so we get that blood clot dam, you know, we can get rid of it, put heat on it, dilate the vessels, get it through. So giving them fluids will help. And of course, we're going to medicate them for pain also. Now, hyperlipidemia, lipids, means fat. It means too much fat in the body. We talk cholesterol, right? Same thing, hyperlipidemia. Now, GI-GU. GI is mouth to anus, and one of our major concerns is alterations in their fluid electrolyte balance due to many things like vomiting and diarrhea, right? And we know that dehydration in children is extremely serious. And we don't want children to get so dehydrated because they can go into total body failure. It's that serious. So projectile vomiting in babies is serious. And there is an absolute difference between just spitting up and then across the room. When I get an infant coming into the ER saying, my baby's vomiting, my first question, does it dribble or does it shoot across the room? If it's across the room, projectile, as in hold the baby up 10 feet away, the garbage can is there, they can hit it. That's how forceful it comes out. And it's caused by pyloric stenosis. So is there a difference between like just reflux GERD and pyloric stenosis? Meckel diverticulum is some little bulge, some little thing that comes out of these small intestines and it tears and there's blood vessels in it and you're going to see blood coming out. And the way that we treat that is we got to go in, got to remove it. Appendicitis, what do you think of? McBurney's point, right? And that's the right lower quadrant. And we tried to get these children go them to ultrasound, figure out, get them to surgery before it perforates. But our biggest risk is when it perforates, because what does it do? It spews all of the contents from the intestines into the abdominal cavity, causing peritonitis, which is a huge infection. Now, Hirschsprung's disease is when the lower distal portion of the colon has an area that has no nerves or aganglionic. So there's no peristalsis, it does nothing. The stool just sits there and it just sits. There's no stooling coming out. So they do the diagnosis, do the treatment, and what they have to do for this child is take out that piece of bowel, and sometimes it's quite a bit, and give a colostomy and allow that intestines to rest. And then usually before the end of the year, they'll close the two parts together. Another GI thing is called celiac disease. And celiac disease is avoiding gluten, wheat, rye, barley, and oat flours, right? Cakes, breads, cookies, very careful with it. And if not, they're going to have severe abdominal pain. So how do you treat it? Well, avoid gluten. They can have milks, they can have dairy, ice cream, veggies, fruit, protein, all of those things, but nothing with breading. No chicken nuggets with breading on it, no mac and cheese, unless it's gluten-free. One of the most common drugs that we see in children, mostly because they like to drink or eat their own medicine, is Tylenol. And it is commonly ingested and it causes liver toxicity. So it is dangerous. Now, as I said earlier, acute glomerulonephritis, again, is caused by a strep infection. And you're going to be seeing this child swell up. They stop urinating and blood pressure goes up. And how we treat the child again is going to be through giving them penicillin. How do you treat chronic constipation? And a lot of children have it. Well, all you have to do is, of course, fluids are important. So we loosen it up, the stool, and then a high fiber diet. Raw fruits and vegetables work better than cooked. What does dysphagia mean? Well, there are some children that have a difficulty in swallowing, and that's what it's called. As I said, tenderness, right lower quadrant, at McBurney's point, we know that's appendicitis. Urinary tract infections, most common in little girls. There's little short, wide open urethras. And sometimes they don't drink enough. Sometimes they don't empty their bladder. Sometimes they wipe the wrong way and could cause frequent bladder infections. So wearing cotton underpants helps. And of course, no bubble baths. They can't sit in that dirty water. One of the things we see with boys is something called a hypospadias. Now, there's a hypospadias and an epispadias. It is, instead of the opening to the penis of the urethra coming at the tip, the hypospadias comes from the bottom. So it is a congenital, and usually before 1 year before they're potty trained, we'll have that fixed. Cryptorchidism is when the testicles on a male fail to descend, one or both, doesn't matter. All right, and let's look at the skin, all different things that can happen. Well, impetigo is a staph infection, and my grandson got it in the back of his leg. My daughter thought he had just scratched too much at night, and I went, oh no, that's more, and it kept getting bigger and juicy and gooey. Really bad, contagious skin infection requiring oral and topical antibiotics. Ringworm is a fungal infection. You'll see like a ring on the skin, and it requires a antifungal cream. Pediculosis is another name for head lice. And of course, we'll treat that with a lice shampoo. Eczema is an inflammation or hypersensitive skin. You'll see some children have these little patches and these itchies, again, requiring some sort of topical. Fungal infections, capitis, sometimes you see those in the head, and sometimes you see, the white flaking, the corpus, the pedis, the crus. These are things that you'll see are other name for fungal. Pediculosis, I already said that, is the head, the body, and the pubic, anywhere, where it's hot, where they can get into. And then there's something called scabies. Usually you catch this if you go to an older hotel, sometimes with old mattresses, and you get scabies. And again, it's treated just like head lice with a type of permethrin lotion and shampoo. Burns, leading cause of death, ages 1 to 4. Children like to play with things, or they like to get next to the stove and pull pots down. It could be thermal, chemical, electrical, radiation, pulling out electrical cords, etc. Remember the rule of 9, okay? And metabolic conditions. When we talk endocrine, you think diabetes and thyroid, right? So diabetes, we have type 1 and 2. In children, especially the small children, they are always type 1. And once they're type 1, they're always type 1. This isn't something they grow out of. The pancreas is not secreting enough insulin. So you're not having any sugar digestion. So this doesn't stop as they grow older. Now, one of the concerns with diabetes is, first diagnosing it. And these are classic signs. Polyphagia, hungry. Polyuria, urinating. Polydipsia, drinking, and they're losing weight. Why are they losing weight? They can't digest sugar. So that sugar calorie is gone. So they're not getting good nutrition. Also, a child who has previously been potty trained, wetting the bed at night, could have enuresis or nocturia. So signs and symptoms to teach the children about hypoglycemia, especially those are, are type 1 diabetes, are old enough to understand. You could have a couple things. Blood sugars on these children can go 20, 30, which is really low. You're going to see they're going to be hungry, they're going to get weak, they're going to get irritable. Older children, they're going to be confused, they're not be able to talk or answer correctly. You see jittery, you'll see paler, sweating, and it gets to the point where they can't even walk correctly. It's almost like they're drunk, okay? Now, what do? You see a child, and that sweating and that jerky and jittery, and you know that they're diabetic. Well, they need something quick to raise that glucose level. It could be a glass of orange juice, it could be milk, it could be a lifesaver, something with sugar, quick sugar, and then they need to get something with protein in them to maintain themselves. Now, an adrenal issue that can happen is called Cushing syndrome. And Cushing syndrome is when you get too much steroids. Usually this is, you've been ordered it for a disease and your body goes into this Cushing syndrome. It's an overproduction that is caused by these steroids of the adrenal hormone cortisol. So you're going to see what? What do these children look like? Well, your big, chunky cheeks, chin, moon face, ruddy, which is like a red cheek. Some students are like, what does ruddy mean? Well, big red cheeks is what you're going to see. Big moon face. They're going to be full in the abdomen, but they're going to have very thin extremities. So you have thin arms, thin legs, big pudgy face, ruddy, and you're going to see a big abdomen type thing. And that's what you see with Cushing. Now, diabetes insipidus is due to pituitary gland, and it's all about fluid management in the body. So you see with diabetes insipidus, you see polyuria, drinking a lot, and thirsty, polydipsia. If you notice, I did not say polyphagia. They're not hungry. It has nothing to do with diabetes mellitus here. This has nothing to do with blood sugar. It's all about fluid, okay? One of the misnomers that most nurses don't really understand. So diabetes is thirsty and urinating a lot. And remember, if you're urinating a lot, you're losing electrolytes. So you have to be careful. Your potassium could go really low. And we also, because you could get into dehydration, assess the current vital signs. Is the heart rate high? Is the blood pressure low? Very important information. Now, vaccines, when we give them, are an acquired immunity. It's because we gave it to them to help prevent preventable diseases. Again, dysphagia is there, difficulty swallowing. And then part of hypertension, dietary approach to stop hypertension diet. In adults, we try to get them on low salt and put them on these diets and exercise. Well, in children, we have found that many of them don't ever need medication. Just limit their fat so they don't get hyperlipidemia. Put them on fruits, vegetables, fish, poultry, and low sodium products. It's not means no salt shaker. These children do very well on DASH. Many times with anemias, we might give erythropoietin. It's a subcutaneous injection. And what it does, it helps with a red blood cell production. So for this exam, as I said, if you need a refresher on dosage calc, I just gave you one, has all the examples of types of questions you might see on dosage calc. Anybody who needs help with dosage calc, send me a message. You don't have to be in my class. I don't mind. I can teach it very easily to you. So know how to change pounds to kilograms and then how to get the proper dosage, okay? I wish you all good luck, and exam 3 should turn out well. Any questions?
I have one question.